Hi, I'm Lauren Grossman, and today I'll be speaking to you about tenosynovitis of the upper extremity. A few of the subjects will include trigger digits, Grossman's tenosynovitis, intersection syndrome, FCR tendinopathy, ECU tendinopathy, and EPL tendinopathy. Trigger digits is a pathologic disproportion between the volume of the flexor sheath and its contents. I added some questions in order to help with the OIT and boards. Which fibroosseous digital pulley is involved typically in the pathophysiology of a trigger finger? The A1 pulley. The most common trigger digits are the thumb, ring, and long fingers. Usually, it's a nodular tendon enlargement at the A1 pulley, but there are other etiologies such as rheumatoid tenosynovitis causing inflammation around the tendons, and the bulkiness of the tenosynovitis causes the triggering. Partial tendon injury, where the tendon where it has lacerated causes triggering as it goes back and forth over the laceration, MP joint and PIP joint deformity, and so forth. On the right-hand side, we could see a nice schematic of the pulley system. You could see the A1 is proximal to the A2 and so forth. It's located over the MP joint. On the left-hand side, we see a nice anatomic dissection of the pulley system. What is the length of the A1 pulley? 7 to 10 millimeters. This is just something that you need to memorize. Into what structure does the A1 pulley insert? The MP joint volar plate. When considering treatment for trigger fingers, it's important to consider duration and the severity of symptoms, whether it's stage 1 or stage 4. Comorbidities such as diabetes, they tend to have a 20% prevalence versus the general population, which is a 2% prevalence, and inflammatory conditions such as RA. There have been some studies out regarding therapy, splinting, and NSAIDs, which haven't really shown that there is much benefit, which with only resolution in about 36% of patients. Steroid injections, on the other hand, have shown that there has been relief of symptoms in more than half of patients. However, there have been recurrence in a little over 50% at a year's time. It did not decrease the rate of surgery in patients with diabetes, so when considering treatment for a diabetic group, might take that into consideration. And there's no evidence that an intrasheath injection is better than an extrasheath injection. When performing a trigger digit release, it's important to make sure you have the correct diagnosis. There are many reasons why a digit may trigger, such as extensor dysfunction, having a sagittal band injury, where you have the tendon sublux into the ulnar gutter and the finger cannot extend because the tendon cannot jump back over to the MP joint. That's a reason for having triggering. There are flexor anomalies, joint synovitis, joint instability, and other sites of triggering. As we see here on the right, there's a mass that's causing the fingers to trigger versus the actual trigger finger. Percutaneous release has been shown to be effective in only 10 out of 240 requiring an open release. You could perform this using a needle or a tenotome. What's important to note are the complications, such as an incomplete release, a superficial tendon injury, or a digital nerve injury. Important things to recognize when performing a trigger digit release is to minimize your soft tissue planes, protect your neurovascular bundles, make sure that you incise your palmar aponeurosis pulley or release it, as that's another site of triggering. And if you're still having difficulty straightening the finger after performing an A1 pulley release, you can also release the ulnar slip of the FDS. In performing a trigger thumb release, it's important to protect the neurovascular bundles as well, especially the radial digital nerve as it crosses over volarly. It's also very important to make sure that you release the oblique pulley with the release of the A1 pulley. That's the A1 pulley, and that is the oblique pulley. Decurvain's tenosynovitis is a common tenosynovitis. It is common among new moms, workers, fishers, and so forth. It's a stenosing tenovaginitis or tenosynovitis of the first dorsal extensor compartment, including the abductor pollicis longus and extensor pollicis brevis. The abductor pollicis longus usually has 2 or more slips, which can cause an increase in volume in the compartment. And the extensor pollicis brevis is a more common site to really have the stenosis, and sometimes it's really a subcompartment or tenosynovitis of the EPB tendon. The sheath becomes relatively stenotic and narrowed, leading to pain and inflammation, causing the tendons to rub back and forth. Typically, how many EPB tendon slips would you expect to find at surgical exploration during Decurvain's release? 1. If you guessed 2 or 3, you'll be thinking of the APL, and it's very important to make sure you're reading specifically which tendon. Here we could see a nice anatomic dissection of the wrist, and we could see here the first dorsal extensor compartments. Important in anatomy, again, the APL, as mentioned prior, that has 1 or more slips. 70% of people have 2 slips. It's palmar and radial to the EPB tendon and has accessory insertions to the trapezium, opponens, and the APB. The EPB typically only has 1 tendon slip, and 30% of people have its own subcompartment. However, in patients with Decurvain's, about 70% of those patients have its own subcompartment. Here we could see a release of the dorsal aspect in order to leave a shelf for the tendons to not sublux volarly. And here we could see a separate subcompartment for the EPB tendon. It's really important to get an adequate history. You check your point of maximal tenderness and perform a Finkelstein's test. What most people think of Finkelstein's test is actually an Eichhoff test. It's placing the thumb in the palm, and the examiner is pulling the wrist in ulnar deviation, causing pain in the first dorsal extensor compartment. You may see a patient jump off the table and have a significant amount of pain with this. The Finkelstein test is a gentler way to find out if a patient has Decurvain's tenosynovitis, which is holding on just to the thumb and pulling the wrist ulnarly. And then there's the Brunelli test, which is holding the thumb in radial abduction, causing pain as well. And you can also put some resistance against the area. Differential diagnosis is intersection syndrome, as where the first and second compartments cross over each other, or the second compartment is stenosed. A neurogenic etiology, which is cervical radiculopathy or radial nerve or sensory branch of the radial nerve injury. The superficial branch of the radial nerve emerges at what interval? The ECRL and brachioradialis. Here's another nice anatomic dissection showing the superficial branch of the radial nerve coming out of the interval of the brachioradialis and the ECRL. Wartenberg's syndrome is another diagnosis which causes pain from the radial sensory nerve down distally. There's basal joint arthritis, STT arthritis, and radial carpal arthritis. Scaphoid fracture causes pain in a similar area, scaphoid non-union, giant cell tumors, just to name a few of radial-sided wrist pain, which all can be confused with Decurvain's tenosynovitis. Treatment considerations include patient education, activity modification, home program or formal therapy, which doesn't help many, and therapeutic modalities. there is the option of trying a brace. However, 70% of patients end up failing long-term using a brace because the brace really only stops the patient from moving in that direction and doesn't really help the inflammation from the deeper veins tenosynovitis. Steroid injections have been shown to resolve symptoms in 62% of patients. However, it is important to consider the risks. Generally, you limit about 2 to 3 injections . Potential complications include depigmentation, fat necrosis or skin thinning, subcutaneous atrophy. In diabetics, you can increase blood glucose for 5 to 6 days, and there's corticosteroid flare. Here we could see, again, the surgical decompression as shown before, showing a shelf for the tendons to rest on, releasing it dorsally so those tendons don't subluxate. So it's important to minimize your risk to the superficial branch of the radial nerve. You make sure you do longitudinal spreading along the retinaculum. You minimize your number of soft tissue planes. Again, you minimize your tissue handling, and you perform early controlled mobilization to minimize scar tissue. You want to make sure that you incise the dorsal retinaculum over the EPP tendon and make sure you've performed a complete decompression, making sure there is not a subcompartment. If there is, you release the subcompartment and can remove the septum, and then you check the tendon stability to make sure that there's no subluxation. Here's another picture showing the branches of the radial sensory nerve, how close they are to the first dorsal extensor compartment where they can be at risk. Intersection syndrome is very common in rowers, weightlifters, and so forth, and can be confused with deeper veins tenosynovitis. But what's important to note that it's more dorsal and proximal. You have pain with flexion and extension of the wrist versus radial deviation, and you hear crepitus along the area of pain. The yellow circles are where the first dorsal extensor compartment is, and the blue circles is where intersection syndrome occurs. Intersection syndrome is pain and swelling due to entrapment of the second dorsal extensor compartment. It's approximately where the first dorsal extensor compartments cross the second extensor compartment. It was previously thought to be due to an irritation of the crossing of the first over the second. However, now studies have shown that it's just entrapment of the second compartment. It's often seen in rowers and weightlifters. Diagnosis is by physical examination and history. There's tenderness to palpation, pain with wrist flexion extension, and crepitus in the area. Conservative management includes splinting and steroid injections. And if all fails, operative management includes releasing the second compartment with a longitudinal incision and leaving the retinaculum open. FCR tendinopathy is another tendinopathy which is quite underappreciated. It's seen quite often with volar wrist pain. It often is a chronic issue. Differential diagnosis is challenging secondary to some of the anatomy in the area as much. FCR anatomy, as we could see here on the right-hand side, shows that it goes through a fibroosseous tunnel and then it attaches to the second metacarpal, going through the trapezium as there's a trapezial tunnel. Diagnosis is subjective history, clinical exam, diagnostic injection is helpful, and imaging. What radiographic finding is associated commonly with FCR tendinopathy? STT arthritis. Here on the x-ray on the left, we can see there's STT arthritis, and on an MRI, it's confirmed. On this image of the MRI, we could see a tendinopathy of the FCR. You could see the difference of the FCR tendon indicated by the arrow compared to the other flexor tendons in the carpal tunnel. Non-surgical treatment starts with patient education, activity modification, wrist splinting, therapy, rehab, and then there are steroid injections, again for both diagnostic purposes, and sometimes it can be therapeutic, but not always. When performing a release, it's important to realize the surgical anatomy and the pertinent anatomy. The palmar cutaneous branch of the median nerve is just ulnar to the FCR tendon. The radial artery is radial. Sometimes you perform a tenosynovitis and a debridement. You release a fibroosseous tunnel, and you can perform a tenotomy for very severe cases. ECU tendinopathy is another common tendinopathy on the ulnar side of the wrist. It can be confused with many other things on the ulnar aspect of the wrist, as Dr. Schwacka will tell you in a future lecture. The ECU tendon is in the sixth dorsal compartment, is in a fibroosseous tunnel, and again, it's ulnar-sided wrist pain, which is difficult to diagnose. It's localized tenderness on the ulnar aspect of the hand and wrist, where the tendon attaches at the base of the fifth metacarpal, and you can have pain that goes proximally. There's the ECU synergy test, which is a diagnostic tool. There's checking tendon stability is very important, and imaging. The synergy test, as we can see here on this video, is you flex the elbow to 90 degrees, you put the forearm in full supination, and then the examiner resists the thumb abduction with counter pressure on the long finger. He is pointing to the ECU tendon. That causes pain to the patient. Differential diagnosis is TFCC pathology, DRUJ instability or pain, LT, midcarpal arthritis, injury, and piezotriquetral arthritis. This MRI here shows again tendinopathy around the ECU tendon, just like the FCR tendinopathy as shown earlier. Non-surgical treatment includes, again, patient education, activity modification, splinting, and therapy, which focuses on range of motion and conditioning. Surgical treatment consists of a release, making an incision along the radial aspect of the compartment, debriding the tendon, performing a retinacular repair, and then tendon stabilization if the tendon is unstable, as sometimes it can sublux and dislocate. EPL tendinitis is another tendinitis which is rarely seen. Most of the time it tends to be seen following wrist trauma such as a non-displaced distal radius fracture or inflammatory arthropathy. Usually leads to attritional rupture of the EPL tendon, but prior to rupture, if it's caught in time, you can perform a tendon release subcutaneous transposition above the retinaculum, which may be preventative of the rupture. If the tendon is ruptured, a reconstruction would be required to restore the function, preferably an EIP to an EPL tendon transfer. And here is a picture showing the patient's left hand able to extend the thumb, but on the right hand side, the thumb is unable to extend. It's very important to make sure the hand is flat down on a table, and then ask the patient to extend the thumb or lift the thumb off the table. That is the best test in order to perform an EPL exam. Thank you.